Today, I'm going to be presenting some of the newer line of research, and I'm going to be presenting one of the research programs, in this case, looking at the endocannabinoid system. This is the presentation outlined for today. I'm going to be presenting why cannabis use is a risk factor for psychosis. I'm going to be introducing or describing to you the endocannabinoid system and its key enzyme, fatty acid amide hydrolase, or FA. I'm going to be showing you how FA can be quantified by carbon 11 curve for the first time in human, and I'm going to be presenting 3 clinical studies. The first one, FA in psychosis. Second one, 2 studies, the first one and the second one, which was a replication study in cannabis use disorder. And the third unpublished study looking at the relationship between FA and glutamate, collectively called as GLX. All right, so as everyone knows, there are very significant epidemiological studies suggesting that cannabis users have an almost twofold higher risk for developing schizophrenia. Experimental evidence shows increased psychotic symptoms, including positive, negative, and cognitive symptoms, secondary to THC exposure, the major component of cannabis, in healthy volunteers, with exacerbations in patients with psychosis. These effects are dose-dependent, and we know that some individuals are more vulnerable than others, but we don't really know why that's the case. Interestingly, many studies have shown, and this is just a summary of them, that younger onset of psychosis is observed in cannabis users together with a sex effect, such that males have a younger onset of schizophrenia, as well as those who use regularly cannabis, especially before the age of 16, or use regularly, meaning daily, have an early onset of psychosis. THC, or tetrahydrocannabinol, mimics the brain's own endocannabinoid system. The endocannabinoid system is composed of 2 major endocannabinoids. One is anandamide, and the second one is 2-AG. There are others, but I'm going to be concentrating on these 2. Both anandamide and FA are synthesized on demand in the postsynaptic cell, and they travel retrogradely. They bind to CB1 receptors and other receptors in the presynaptic cell, and by doing that, they regulate other neurotransmitters release. They regulate the release of glutamate and GABA, for example. Endocannabinoids are important. They provide negative feedback to synapses. They are involved in memory, learning, brain plasticity, neuronal development, and the regulation of stress and emotions. They prevent excitotoxic activation, and by doing that, they fine-tune synaptic inputs that are also involved in learning and memory. So far, all positron emission tomography studies have only investigated the CB1, or the cannabinoid 1 receptor. First study by Dean Wong in 2010 using carbon 11 OMR and a simple method of analysis in a small sample reported a 15-20% or so CB1 receptors in patients with schizophrenia. Cesarini later on in 2013 with a larger sample but a relatively poor radioligand and quantification method reported a slight increase in CB1 receptors as well in patients as compared to healthy volunteers. More recently, the study from Mohini Ranganathan in Yale, together with the MITSI group in Europe, have used improved radiotracers or improved quantification methods. And by doing that, these studies in a relatively larger samples were able to show a reduction in CB1 receptors in schizophrenia patients, first episode psychosis mostly, but also in older patients, as compared to healthy volunteers with a relatively higher percent changes using improved quantification methods. Similarly, anandamide, which is the major endocannabinoid, as I've explained to you before, which levels are regulated by FA, has also been shown to be elevated consistently in CSF, or cerebrospinal fluid, of patients with psychosis. And this is a summary of those studies. As you can see today, all the studies have shown an increase in anandamide levels in patients with schizophrenia, as well as in those at clinical high risk for psychosis as compared to controls. As I've explained, FA is key to regulating the levels of anandamide, and FA can be quantified with carbon 11 curve. Carbon 11 curve is a selective carbon 11 radio-labeled FA suicide inhibitor, matches the known distribution of FA in human brain, as you can see here, been shown to be quite reliable with excellent test-retest reliability and to be quite selective. Here you have a baseline scan of carbon-11 curve, and on the right here you have another scan with carbon-11 curve after pretreatment with selective Phi inhibitor. The signal is completely ablated, showing that carbon-11 curve is highly selective to quantify Phi in brain. Here, Isabelle Boileau in Toronto, who led some of these studies, has also shown that there is a polymorphism in the Phi gene that regulates Phi levels in brain. Those who have an AA genotype have significantly lower curve binding, consistent with higher Phi levels, higher anandamide levels, as compared to CC. There's a very small group of the population who is AA versus CC, but this population actually have very high levels of anandamide. There's a very famous case of a woman, a Scottish woman, whose article came in the New York Times because she had a complete knockout of Phi. This woman, even below here, one would expect, and this woman has never ever felt in her life either pain or stress or anxiety. So Phi, it's a terribly important enzyme in the brain, which can be actually quantified by curve. Because of this, we wanted to measure the enzyme, the endocannabinoid enzyme Phi in vivo in patients with psychosis using carbon-11 PET. We used lambda K3 as the outcome measure, and we hypothesized that curve binding in the dorsolateral prefrontal cortex, striatum, amygdala, and hippocampus will be significantly lower in patients as compared to controls. Being lower, it means that there are higher anandamide levels, as it has been shown in the CSF studies for anandamide and consistent with a reduction in CB1 receptors. We wanted to examine the relationship between regional Phi levels, indexed as curve binding, and psychopathology in schizophrenia, as well as the relationship with psychotic symptoms. We chose these ROIs of regions of interest because of their overlap with CB1 receptors and as well as their evidence of their involvement in psychotic-related symptoms. So this is how experiment looks like. Patients come in for a medical and drug use history assessment. We also assess psychotic symptoms and recent stressful life events. Everyone goes on a carbon-11 PET scan with arterial sampling in the HRT or high-resolution laser tomograph. Everyone has an MRI scan that is used to perform the kinetic analysis. For carbon-11 curve, the two-tissue compartment model with an irreversible compartment has been found to be the best model to quantify Phi in brain, with lambda K3 as a validated outcome measure with excellent test-retest reliability. So this is the first study, which was published back in 2020, and you can see that we have healthy volunteers, relatively large sample for PET using arterial sampling, and a subject of psychotic disorders. These were young people, mostly in the first episode of psychosis. Most of them were male. As you can see here, some of them were tobacco smokers. And as you can see, there was no significant difference in the radio tracer parameters between the groups. Most of these patients had schizophrenia diagnosis. However, there were many others with either other psychosis diagnosis, such as a schizophreniform diagnosis, schizoaffective, or psychosis NOS. Most of them were antipsychotic free or not taking antipsychotic medication at the time of scanning. However, some of them were. However, this was regularly in low doses. Some of them were taking other medications, as you can see here. This is the main outcome of the study. All the figures you'll see today, they're going to look quite similarly. On the y-axis, you will have carbon-11 curve, lambda K3 values, and on the x-axis, you have the different brain regions with the prioritized regions described here. Phi did not differ between patients and psychosis and healthy controls. And this outcome did not change if we take into consideration as well past year cannabis exposure, cigarettes per day, tobacco use per day, or antipsychotic dose. What was interesting is that consistently across the whole brain, lower Phi levels predicted greater positive psychotic symptoms, and this happened across the whole brain. As you can see, higher psychotic symptoms was associated with lower curve binding, and this was observed with a significant effect size of medium to large effect size. And this is consistent across the whole brain. We also observed that Phi was 9 to 12% higher in females as compared to males. And this, however, has to be taken into consideration that most of the patients that we have scanned were males as compared to females. The next set of studies I'm going to be presenting are two studies. The first study conducted by Dr. Boileau, and the second one was a replication study we did together in a younger population. As you know, preclinical and postmortem studies show decreased CB1 receptors with cannabis use. PET studies also report a downregulation of CB1 receptors in cannabis users. Genetic studies show that Fa variant with higher levels of an enzyme, the CLL I just described to you, is associated with greater CUD or cannabis use risk and cannabis-related problems. Interestingly, treatment with the Fa inhibitor reduced cannabis withdrawal symptoms in men with cannabis dependent, as has been reported by Cyril de Souza in the Lancet Psychiatry relatively recently. So because of this, we wanted to measure the enzyme Fa in vivo in cannabis users, and we hypothesized that curve binding with lambda K3 as outcome measure in these brain regions will be significantly lower as compared to healthies. This is the first study that was carried out in a relatively older population, not really very old, but there were people in the 40s, way younger than me. And you can see here that there were no significant difference in PET parameters. As you can see here, there were differences in smoking status, as can be observed here as well. And most of these people started to use cannabis at the age of 16, and they have had about between 10 and 17 years of cannabis exposure. As you can see here on the y-axis, you have Fa levels or curve lambda K3 values, and on the x-axis, different brain regions. And as you can see, Fa is significantly lower in cannabis users as compared to healthy volunteers. Now, in this study, as well as the next study, in a younger population, as you can see here, with a mean age of 22 years old and a healthy volunteer group of 21 years old, regular years of cannabis exposure is less because these people are way younger. They have started to also smoke at the age of 16 years old, but you can see their relatively early exposure is below 10 years in this case. There are no difference in PET parameters that has been shown previously. And of course, similarly, the cannabis users also are more significantly users of tobacco. Again, as you can see here, Fa levels are lower in cannabis users as compared to healthies. As you can see here, the percent difference are slightly smaller than those observed in the regular cannabis users with longer cannabis exposure, lifetime exposure. However, this study is a replication of the previous study in a younger cohort, suggesting that indeed people who use cannabis and who meet criteria for cannabis use disorder have lower Fa levels as compared to healthy volunteers. Now, of note, these were people who were not in acute withdrawal. People were allowed to continue using cannabis to the levels they were using previously. They were just asked not to smoke cannabis the night before the scan. Everyone was scanned in the morning, and this was done to prevent intoxication during the scanning. Now I'm going to be presenting the final study, and this is not yet published, but hopefully very soon. The endocannabinoid system, as you know, as I've explained, regulates neurotransmitter release. And so it's theoretically plausible that Fa can be associated with other neurotransmitters, such as glutamate and glutamine. Because I'm going to be presenting data on a 3T scanner, I'm going to be calling this the GLX, which is a standard in the field. In preclinical studies, overexpression of Fa in hippocampus led to elevated spontaneous glutamatergic and GABAergic neurotransmission. And also hippocampal CB1 receptors were associated with GLX concentrations in anterior cingulate in previous studies. So because of this, we wanted to investigate the links between Fa and hippocampus GLX. So we are actually measuring GLX with MRS in this group, in a group of young adults with and without psychotic disorders. And we hypothesized that low Fa levels in patients would be associated with higher concentrations of GLX. We use standard MRS techniques as developed by Dr. Pada Sailai-Susta in Toronto, and we use a stringent quality control procedure developed by her and followed by the graduate student at the time, Dr. Watts. And this is a subgroup of the previous study. This is a group of patients and healthy volunteers who did the Carol 11 curve scan, as well as the MRS acquisition for hippocampal GLX. As you can see, this was a relatively young population, and they were not using significant levels of antipsychotic medications. What you can see here is that indeed higher Pha was associated or is associated with greater hippocampal GLX in all regions sampled, and this was irrespective of group allocation. So in other words, this association between Pha and GLX is not altered in patients as compared to healthies. So in summary of results, there was no difference in curve binding between schizophrenia patients as compared to healthy controls. Patients with stronger positive symptoms tend to have lower curve binding. Putative trend level sex difference in curve binding highlights the importance of sex match control groups. Lower curve binding in cannabis users, including cannabis users, have been shown twice, and higher curve binding was associated with greater hippocampal glutamine or GLX concentration. Hopefully we can discuss some of the interesting science that I presented today here. Just before I finish, I want to ensure that I acknowledge the support of all these studies from NIMH, the excellent work of Dr. Boileau, Dr. Tyndale to quantify these levels, the levels of the genotype in these patients. I want to thank the patients and the families for taking part in these quite invasive and difficult studies. For this, the work of Jeremy Watts, as well as Maya Jacobsen, who worked both on the schizophrenia Pha work as well as the cannabis work. Collaborations from many people, Dr. Rushton, Dr. Wilson, Dr. Hull, who are instrumental in supporting the study, as well as here, Ranjini Garani, who moved from the University of Toronto to McGill to pursue her studies here in IPM.